We've developed a lot of sort of skills in our practice doing this face-to-face with folks. And now that a lot of organizations, including public health departments, community-based organizations, community health centers, have had to adapt given the reality of COVID-19. Some are either rolling out or thinking about rolling out what I sort of think of as teleguided self-testing. So it's not necessarily that you're just sending a home testing kit to someone, but you're actually sort of virtually doing that encounter. And from folks that I've been talking to, this can be kind of challenging. So this is really about a conversation and seeing where we all as peers can learn from each other and share resources. But I am also going to provide some definitions and grounding fundamentals just so that we're all on the same page. And as Jose mentioned earlier, I am with the Hands United Capacity Building program. We are track B in the South, meaning that we offer technical assistance to all 19 Southern jurisdictions and their funded grantees, specifically on testing in non-clinical settings and prevention with folks that are not living with HIV, but are at high risk. Hands United is funded by the Centers for Disease Control and Prevention under PS 19-1904. And as I mentioned earlier, we offer customized, tailored technical assistance to increase the capacity of health departments, CBOs, community-based organizations, and other service organizations to provide HIV testing in non-clinical settings and prevention programming for folks whose status is negative or neutral across the Southern US. So what's kind of the goal of the community, what we're terming the Community Learning Lab? We really designed it to offer a virtual space for peers in the field of HIV prevention and care to learn from each other. Ultimately, our goal is to create a learning environment where we can each increase our knowledge base to more effectively engage priority populations in HIV prevention and testing in non-clinical settings. We hope that with new knowledge and new sources of networking, we can all continue to end the HIV epidemic, guided by the four pillars. So diagnose by increasing awareness of status via HIV testing. 2, treat, depending on the results of the test, effectively engaging folks diagnosed as living with HIV to care and needed services to achieve viral suppression. And or 3, protect, depending on the results of the test, effectively engaging folks that are not living with HIV with prevention methods, services, and support to remain HIV negative. So thinking about the utilization of PrEP as one of those options, and respond to clusters quickly. Note that for the purposes of our Community Learning Lab, we won't be touching on techniques related to identifying and mitigating clusters or surveillance. However, we want you to think about, or we ask that you think about the respond pillar in terms of being culturally responsive, and consider how this approach will help you in successfully utilizing the first 3 pillars in your work. And so what's our intention for today? So today, it's not really going to be how we formulate a whole lab, which has a couple of different sessions, but a community learning lab conversation. And we really, again, just want to provide a space for an open learning environment and support through discussions with peers in the profession of HIV prevention and or offering testing in non-clinical settings. Our specific learning lab conversation objectives for today: we're going to review brief risk screening. We're going to learn new tools and techniques applicable to brief risk screening, or BRS, during a telehealth encounter. and share resources and real world best practices that you yourselves are utilizing. And then we're allotting time throughout and then at the end for discussion and questions and answers. Ideally, the audience that we designed this for are providers offering HIV testing in non-clinical settings, guided self-testing virtually, and prevention services, including PrEP and PEP. However, if you don't necessarily fit into those particular categories, that does not mean that you can't participate and hopefully gain something from being here with us today. So just a couple of participation principles for the Community Learning Lab. This is really not set up to be like a lecture where I just present material and you can kind of sit back and kind of take it in passively. We really want this to be as active as possible. So we're asking folks that at different points, use your chat function to respond, or you can raise your hand or unmute your mic to participate. That's the only way we can really make this useful for you all and worthwhile. The topic is relatively new, so quote unquote, and many of us have had to adapt quickly and still are figuring things out as we go. So I want to acknowledge that. I ask that everyone please be respectful, treat folks on this platform with dignity, use I statements as much as possible, and speak from your own experience. Always remember about maintaining confidentiality if you're thinking about sharing a particular example in your work. And please do leave space for fellow participants. Not everyone feels as comfortable or as able to sort of jump in and start sharing. All right. So with that, let's start off with a poll. And for this poll, it's actually a multiple choice. And I'm hoping this will work. And the question is, in the context of HIV testing, in non-clinical settings, what is meant by brief risk screening? So I'm going to launch this.
I went ahead and launched it for you, Gabriela.
Oh, you did. So is that coming up on the screen? Because I don't see it.
Yeah, we're getting some responses coming in.
Yay.
And just let me know when you'd like me to end it.
Let's give folks a couple more seconds. Like I'm actually not seeing what the polls coming in. So if you're seeing, we have 39 participants, you can kind of gauge.
Yeah, we got about 19 folks responding so far.
Okay. Let's give it a couple more seconds. In the context of HIV testing in non-clinical settings, what is brief screening? If some of you are calling in, I'm just going to name the options. So number one of the 6 elements of conducting an HIV test. 2, a process during the testing encounter between the tester and client, where the tester finds out what brought the client to decide to test and assesses for possible recent exposure to HIV. 3, a checklist that the client has to check off their lifetime sexual behaviors. 4, all of the above. 5, none of the above. 6, I am not sure. Okay, Jose, let's stop it and post the results.
All right, and I'm not sure, I hope you can see these, but I can let you know if what the results were. So we got 56% chose a process during the testing encounter between the tester and client, where the tester finds out what brought the client to decide the test. And then the second highest option at 38% was all of the above. And then following that, to round out the rest, was one of the 6 elements of conducting an HIV test. And those were our 3 top choices.
Okay, excellent. So for those of you that chose one of the 6 elements of conducting an HIV test, that's absolutely correct. And if you also chose a process during the testing encounter between the tester and client, where the tester finds out what brought the client to decide to test and assesses for possible recent exposure to HIV, that is also correct. However, in the context of HIV testing in non-clinical settings, brief risk screening actually is not a checklist that the client has to check off all of their lifetime sexual behaviors. So we're going to go through a review of brief risk screening in the context of HIV testing in non-clinical settings. What you're seeing here are the elements of an HIV test. So thinking that although an HIV test result does not ensure linkage to care, it is a crucial step for activating and engaging the continuum of care and prevention. So let's review these 6 core elements of steps involved in an HIV test. 1, introducing and orienting the client to the session. 2, preparing for and conducting the rapid HIV test. 3, while that's happening, conducting brief risk screening. 4, providing the initial results and following your protocol for confirmatory testing if needed. 5, developing a care, treatment, and/or prevention plan based on those results. And 6, referrals and linkage to medical care, social and behavioral services, any other support services that may be needed at that time. So just to kind of make sure that everyone understands that our time together today, we're not going to do a training on the delivery of HIV testing, but just so you all know that the delivery and development of those core testing steps is something that you can receive technical assistance for, and that's available at your request. My apologies, I just had something weird happen to my screen. Okay, so we're going to be honing in on step 3 to conduct the brief risk screening. And then we're going to take that information as kind of like a foundation and see how we've been adapting that, what challenges, what sort of perks we've had in the telehealth environment. So we're going to define the elements of effective screening for HIV risk factors in the context of testing in non-clinical settings. And we're hoping that this section is just going to give everyone a review of where screening and assessment are similar, where they inform each other, and where they might differ. And it's also a review of where to place the screening and assessment actions in the testing process. For example, ongoing risks that you've identified during that brief risk screening process is where you may think about possibly linking someone to a referral and an actual linkage to a PrEP prescriber and other prevention services. So here's here's like the 4 elements of the brief risk screening. You ask and discuss, you listen and observe, you provide information, and then you prepare for the results. So what do we mean by ask? Pretty simple. What brought you in to get tested today? Or tell me why you decided to come in today, or what specific concerns do you have about HIV? Those particular questions, the intent may not necessarily change when you're doing a teleguided self-testing session virtually, because the person hasn't necessarily come in anywhere. You're sitting wherever you are and you're engaging with them wherever they are through a virtual platform. But the intent is still the same. Like, what made you decide to get tested today? And why did you decide that? And what specific concerns do you have? For the listen and observe. So observing can be very challenging when it's going on through a virtual space, right? But what are you listening for? Same. Is the client in the window period? Has the client been exposed or possibly exposed within the past 72 hours? Are they sharing with you, describing an ongoing risk? Are there any signs of acute infection? Again, that might be very challenging through the virtual platform, but it's something that you still need to be mindful of, recognizing that you're within a different environment. Note that regardless of the testing technology, rapid, instant, or non-rapid, all testing encounters start with first with the intro and orientation, and that's not going to change when it's a teleguided self-testing encounter, followed immediately or soon after by the brief risk assessment. Same. Elements of brief risk screening occur simultaneously and flow. They include ask, listen, assess, prepare, and respond. Ask, listen, and discuss. Ask, listen, discuss, and observe. Assess and prepare to respond with further probes, information, clarification, and referrals. So again, this might be a little challenging in part because it's new. This is a new platform for us to be using the virtual space. But this is what we hope that can be helpful to you all in this community learning lab conversation. We, in HIV testing in non-clinical settings, we aimed for the risk screening to be relatively brief, although that doesn't mean that it has to be brusque, like boom, boom, boom. But we usually think about it between 5 and 10 minutes, maintaining a grounded, non-judgmental, and engaged demeanor throughout in a conducive environment to the interaction with the client. Now, given that, again, this is a virtual space that is not only new, possibly, for the client, but also for you, you may need to consider that that might take a little longer just because you're establishing this rapport, and rapport doesn't happen quickly under the best of circumstances, but can be really challenging when you are interacting with someone. As humans, we're used to this in our brains that it should be person to person, but we're doing this through a screen. So just again, to go by each of those steps within the brief risk screening process, while asking and listening, check in with your client and with yourself. You do not want to passively listen. You want to use your skills to listen actively, closely, and responsively. Use open-ended questions and probes. Actively listen and probe for previous testing history, results, and indicators of increased risk. So sexual risk, injection use, those behaviors of the client and their partners. This is challenging, again, through the telehealth and virtual platform, which is observing tone and body language in addition to the client's words. So that means that we're going to have a different sort of, we're going to have to develop some different skills when it comes to that. And keep a lookout for possible indicators of acute infection. By that, we mean to closely listen and probe for increased risk, including potential exposure in the last 72 hours, where there may be a need for NPEP. Potential exposure in the last 3 months, where someone may possibly need retesting and some extra counseling for reduction of exposure. And then symptoms, indicating a possible need for acute infection testing in the lab and accessing medical care. Again, something that is challenged by our current reality when it comes to COVID. When we are thinking about being responsive, well, what does that mean? Be responsive to the client's identified needs along the continuum of prevention and care. Assess readiness, discuss barriers, prepare for the next steps. For example, the need for PrEP and PEP, the need for HIV medical care, the need for essential support services, assess the client's readiness to accept a referral, and discuss possible barriers and forecast approaches to overcome and identify next steps. And I think that this is also important to, again, place in the reality of COVID, because one of the needs may be actually in relation to the pandemic. There may be anxiety related to that. There may be other forms of basic needs that may be related to that. And then what do we actually mean about the range of providing information, referrals, and linkage? So depending on what information was elicited from the person that you're working with in the teleguided self-testing encounter, they may you need to be thinking about being prepared to selectively provide HIV testing again, and maybe referral if there's acute HIV symptoms that are being noted or are being disclosed. STI testing, so sexually transmitted infection testing, linkage to viral hepatitis testing, and STI vaccination, so possibly for HPV. Linkage to PEP within 72 hours of exposure. Navigation to PrEP clinical care, navigation to HIV care and treatment, referral to substance use treatment, syringe service programming, referral to other high impact prevention interventions and strategies, and again, linkage to essential support services. In practice, it's important to apply these definitions to our real world scenarios as providers and CBOs offering testing in non-clinical setting for our community members. So ask yourself these questions. What are you screening for? We're screening for behavioral risk for HIV in this particular case of self-testing through a teleguided virtual encounter. How are we screening? Thinking about the technology that is being used and the implications for that technology. Who exactly are you screening? What is your priority population? How is that similar or varied when you're now doing your self-testing efforts? What are the characteristics of that priority population and how are you finding them, or for lack of a better term, recruiting? Why exactly are you screening? Like being really specific about eligibility criteria or a risk profile that is guiding your effort. And in theory, why that is justified. Like why is there a higher likelihood of HIV? And what will you do when you have completed the screen, the actual test, depending on the result? What are the implications and considerations for linkage, navigation, partnerships, your staff, flow, and organizational capacity? And again, now thinking that in the teleguided encounter, this is within the context of COVID, of the pandemic. I like to bring this slide up because I think it's important that we all know why testing is important. And I know this may be, it's not new, but I think it's important that we're all on the same page. So we see that testing is a critical component of the HIV prevention and care continuum. The core steps of the prevention side of the continuum include an individual is tested following the 6 steps that we were mentioning earlier, and receives a diagnosis, either non-reactive, HIV negative, or reactive, a positive test result. Then they are linked to services responsive to their result. Prevention for those that are diagnosed negative, care for those that are diagnosed positive. Our aim, our hope is that they successfully engage and are retained in services such as ongoing counseling and support and outreach services as needed. And then 4, that they either remain negative or achieve viral suppression for those folks that are living with HIV as a form of adherence. Although an HIV test does not, like I said, ensure linkage to care, it is a crucial step for engagement. Okay, so now that we have that first sort of fundamental piece that we're all on the same page about, which is what is testing in non-clinical settings, the 6 steps, the brief risk screen, the real purpose and the critical importance of testing, let's start to put puzzles together, given the reality of COVID-19 and how we've had to adapt. So I'm going to ask Jose to launch poll number 2.
All right, and it's on folks' screen right now.
And for those of you that may be calling in, the question is, given the unexpected shifts to service delivery due to the impact of the pandemic, how many of you have experienced challenges to adapted screening for self-testing efforts? So I'm not actually asking about the actual self HIV testing in and of itself. I'm actually talking about that specific element, which is the screening aspect of it, the risk screening aspect of it. So how many of you have experienced challenges to adapted screening for self-testing efforts, if at all? This is not multiple choice, so just choose one. The first, you can respond by, we are experiencing significant challenges to the screening process during the self-testing encounter, meaning the teleguided self-testing encounter. 2, experiencing minor challenges. 3, not experiencing any challenges at all. 4, not sure. And 5, we're not offering teleguided self-testing at the moment.
So we got about 50% of responses in. I see some more coming in, so maybe a few more seconds and we can reshare the results. So far, it looks like the majority of the folks in the room, though, have indicated that they are not offering teleguided self-testing at the moment. So just let me know when you'd like me to close it.
All right, let's close it now. I'm going to make sure that we have time to do a little debrief.
So I'm sharing the results on the screen. Attendees should be able to see them now. But 40% of our respondents said that they were not offering teleguided self-testing. That's about 10 folks. Following that, we saw that the second highest response was that they were experiencing, the second one, which was that they are experiencing minor challenges to the screening process during the self-testing encounter. And so that was about 7 folks. And then we had about 5 folks who were maybe not sure. If you want to share a little bit more, maybe you can put that in the chat for us. And then the other 2 got about 1 or 2 responses each.
Okay. So again, I thank you so much, Jose, for kind of giving me the breakdown, because for some reason I can't see the breakdown. But from what I'm hearing, it's a range, and I think that at least that resonates for me from as a technical assistance provider, from what I'm hearing, and also from what I think what we would expect given the circumstances. So I'm gonna ask you all for some active participation, and either using your chat function, or if you feel comfortable, to unmute yourselves and share with us, for those of you that have been experiencing challenges, regardless if it's minor or major, what have some of those challenges been, and to just sort of share in your own words. And I don't think I can see the chat, Jose. So if you can.
I just put a message in the chat, so we'll see if we can encourage some folks to share. I did see somebody hop off their mic. Dante, do you want to go ahead and share some of the challenges you've been facing?
Yeah, so we have been doing teletesting or teleguided testing for about a quarter now. And for us, one of the challenges around screening is, so folks express interest through a survey on our website, and patients aren't interested in doing a screening. They'd like to just receive a test, and have their results. But screening feels like a hassle for them. They don't want to answer questions. I mean, I think all of us providers in the South, we are very used to dealing with stigma. So I'm sure that colors and affects why patients aren't interested in doing a screening. But I do think it's more of the culture of just kind of teleservices. Folks kind of treat teleguided testing like it's Postmates or Uber Eats. They want the service, but they don't necessarily want the doing things like screening. And also, I think our screening is long. We're asking a lot of questions. So those are kind of some of our challenges is people being hesitant to do the screening process or feeling like it's a hassle.
Gotcha. Okay, thanks for sharing, Dante. Anyone else?
Yeah, I know that we have some folks from Florida and Houston in the room. I'm seeing Nkichi from Legacy Community Health just shared in the chat that they agree with Dante, and doing it over the phone rather than through video calls makes people hesitant. So the particular telehealth modality seems to also be something that changes the experience as well. I wonder if other folks have been experimenting with phone calls or video calls that they might want to share. I want to hear somebody from Florida. Anybody from Florida want to share?
Well, while folks are sort of thinking, if they do want to share, and it's okay, because I think again, this is all new, and it's okay to sort of process this. And I do appreciate those of you that are actively participating, because that's how this was all designed. So one thing that I think is really key with what both Dante and Nkechi is also sharing is that that aspect of the actual client. So like the client that kind of just wants the test and to kind of do it on their own, and boom, that's it. And so thinking about how there may be different strategies. So that might be one option for our clients, but another option may be that there are folks that might be very interested in the self-guided telehealth encounter. I think another thing that I thought was really key with what was shared was, again, like the screening and the assessment part being long. And that's something that is challenging, because depending on your local jurisdiction's requirements, there may be a long assessment that needs to happen. The way that brief risk screening kind of played into the testing in non-clinical settings flow was that, at least within that very specific testing encounter, there would not necessarily be a need to have this sort of long risk assessment, but that really it was kind of just about like, tell me why you came in today. Let's talk about like your, possible exposures in the last, 6 months, 3 months, to kind of really get at like, depending on the result, that's where you get the prompt for further conversation. And the onset of COVID and having to adapt to virtual telehealth has kind of flipped that a bit on its head, because of how we have to collect certain data for funders, and then what we want to make as non-cumbersome as possible for a person to just to know their status. So thank you so much for those of you that are sharing. And these are some of the things that I've kind of looked through the literature, and also that I've been hearing as a technical assistance provider, but also just someone who still has folks that are working in direct services. So for the purposes of our time together, we're just going to focus on number 1 as far as challenges and touching upon 2 and 3. In reference to number 4, insurance coverage of telemedicine service varies widely based on the insurance plan and state policies. Insurers typically pay lower rates for telemedicine compared to in-person care, and patients may pay out of pocket for services normally covered in full in the clinical setting, including just so you know, contraception and STI screening. So this is from a Kaiser Family Foundation policy brief. You'll be getting all the references and resources that were utilized to put this together. But just so you know, as such, number 4 is beyond the scope of our time together today. So some of the common challenges: establishing rapport for screening, the delivery of results, and subsequent linkage depending on the information elicited during screening and test results, confidentiality and privacy. But there are some common perks as well with entering into like a telehealth and at least having an option for for telehealth platforms. So let's note those possible benefits or perks. Telehealth options can increase accessibility to and acceptability of HIV testing. So I think for those of you that shared that specifically within the context of the South, although I think that a lot of jurisdictions across the states and the 6 dependent areas can attest that stigma is a barrier. Telehealth actually can increase acceptability of HIV testing as well. This may be more salient for folks in rural areas and or areas with limited to no transportation options, for those that have to travel really long distances to a venue, for folks where their work-life schedules may not match up with what we think of as traditional office hours. As I said earlier, concerned about or have experienced stigma and or violence related to perceived HIV status or just accessing testing. But what you see on this slide are, again, it's from the Kaiser Family Foundation policy brief, and it really depicts the range of interactions that telehealth may facilitate, along with the location, devices, and modalities. So I want you to take a brief look at that and tell me if anything is missing. And you can either unmute yourself or put it in the chat, because one was strikingly missing to me. So when it comes to interactions, patient-provider, provider to provider, that telehealth can facilitate that interaction. As far as devices that can be utilized, smartphones, computers and laptops, tablets, and or a monitoring device. When it comes to location, I'm kind of being a little like, you can think of at home or wherever your sort of personal space is, although we have to be mindful that some folks may be living in residential facilities as far as like shelters, et cetera, and that may most likely impact privacy and other concerns. A clinic or a hospital. And then modalities: video conferencing, storing and forwarding, remote patient monitoring, text, call, email, message. So someone shared like location outside. Absolutely. That's one location that's actually missing outside. Anyone else? I'm going to give a couple more seconds and then I'll share mobile location. Thank you. Yes. A mobile location, like a testing van, absolutely. That's another location that's missing from this and could be a perk. Anything else? Okay, so I'm going to reveal what I thought was missing, which is the community-based organization. So that for some reason is not listed in the location. And I think, again, that's really important, especially as we move forward through the reality of the pandemic, which is that community-based organizations are often the trusted sources for health information, for services. And then that's why it's also important to think about actual partnerships. Yes, and that does include community faith organizations, so faith-based organizations as well. Thank you, Luz. But we also know, so kind of going back to the different platforms and modalities, that there are, I term it digital disparities. I've heard the term digital poverty or technology deserts, but basically that means there's variation in teledevice literacy and or comfort to utilize. So what can we do to ensure that we don't further magnify health inequities when it comes to telehealth? And my question to you all, again, some active participation. What strategies have you and or your organization utilized to ensure or at least reduce the likelihood of further magnifying health inequities when it comes to telehealth? And I'm going to pause there so that you have time to either share on chat or unmute yourselves. And remember, this is how we all can learn from each other. And I'm going to...
Gabriella, I did get a couple DMs from some folks saying that, or private messages, I mean, saying that they haven't started their telehealth program yet. And so they're definitely very interested in hearing from other folks on the call who have already been doing this. So just an extra incentive to share any strategies you might have had in case you...
Remember, y'all, sharing is caring. So I appreciate for those of you that haven't started yet and are really trying to be mindful about pre-implementation and rolling things out. But yeah, for those of you that have, what are some of the strategies that you're utilizing? And I'm going to do a time check.
Good morning.
Yes.
So I'm from Central Arad here in Puerto Rico, and we do not do a brief risk screening, but what we do is that we text all of the participants that ask for the test, and we do follow-ups. So basically, we ask them if they got the test, if they want to give us the result, and we ask them also if they want linkage to PrEP if the result is negative, which has been a very good strategy, although the amount of people that have answered is on the lower end, about 50% of the participants, and that is including text and calls. So me particularly, I've been calling every single participant that we've had, and I think that that has been like the amount of people answering has been higher. Although a problem that we faced is that some participants can give a phone number that's not even theirs. So how can, and I ask everyone, right? Can we tackle that problem? You know, because they can write whatever phone number they have on the form that we give them.
Yeah, thank you so much for sharing that. I think like there's a couple of things that really resonated from what you just shared with us. And one is that, so you're utilizing texting, and it sounds like you kind of also are using texting and an actual phone call. So kind of using multiple ways of engaging with the person. And that might be helpful when we're thinking about folks that either, don't necessarily feel comfortable with like texts, maybe older folks. But I guess what I'm getting at is like the ability to be nimble enough that you're utilizing like a couple of different sort of strategies and options, like not just one. But then the other key thing that you brought up, and I think that that is something that I have heard, and that is the issue of follow up, but also ensuring like the privacy aspect, so if someone is giving you a phone number that is not actually theirs to sort of control. And I'm just putting that out there because I think, again, these are all things that if you're kind of rolling out your programs, this is a great opportunity because you're actually piloting and testing something. So kind of like collecting your own data around this and sort of being able to prove to folks later on what worked for you and also share. But also for those of you that are in pre-implementation phase, these are key considerations. Someone else shared a local, let me lower this a bit, sorry.
I can read the chat if you like, Gabriela. Yes, so we did get a couple of responses for some folks, and one of them suggested one strategy that a local FQHC has been using is expanding their Wi-Fi into the parking lot, right? Typically, Wi-Fi is restricted within the building walls, but expanding it into the parking lot. So that's one strategy. And another one that we got from Luz actually was very charming. That is called Un Café con Luz, right? A coffee with Luz, where folks can schedule a time to meet one-on-one with Luz and get some of the educational materials around sexual health as well, including brochures and testing kits. And we did get a question coming in from Liddell as well. And that question is there a way to communicate with folks before they get the test kits? That way, if they gave you the real number before they got the test kit. So bringing us back to those follow-up questions that you were just talking about. But yeah, so we got Wi-Fi and some one-on-one meetings.
Yeah. So I think like on my end, I can share that a program that I've worked with the Latino Commission on AIDS, like, is a faith-based program, the Latino Religious Leadership Program. And that was a big issue, which is the digital literacy and what we think of as like digital poverty. And we did like a brief, but I think really critical assessment of where folks were in our program when it came to technology, what the issues were. Was it actually having the devices? Was it actually being comfortable or knowledgeable of how to utilize? Was it more structural, so like internet access, bandwidth, etc.? And it was kind of a combination of all. And so we kind of did like almost like aside from the health education work, there was sort of orientation and education around technology, uses of devices. But also one thing that came up in the assessment that was thought about was actually almost like pairing folks up. So you had like a digital buddy, which sounds a little weird now that I say it out loud. But anyway, there's different strategies, and I don't know the answer. I don't think any of us do, but I think it's something that I know on my end, I'm like kind of jotting down because, I'd love to do like a follow-up to this and kind of give more, focused technical assistance around like how to deal with follow-up situations where you have a number that no longer works or actually was never the correct number, blah, blah, blah. So thank you all for sharing. Thank you for sharing, those of you that have resources, because you're actually testing stuff out. And thank you for those that are being transparent about you haven't launched anything yet, but you're interested in learning. So this is something that I thought was important, and this actually is what originally kind of led me to think about this particular community learning lab conversation. And so some of us, as we've been seeing, have already had self-testing programs as an option for our community members, or as a tailored program for focused populations. So given resources, et cetera, maybe you're meeting a particular eligibility criteria. For some of us, this is an entirely new venture and was initiated to continue offering services and keeping folks engaged during the onset of the COVID-19 epidemic. But regardless, the fact remains, we are now offering this option, or going to be offering this option, during a really tough time for folks, for our community members, for our staff and colleagues, and for ourselves. Living through the experience of a global pandemic, I don't mean to laugh, but it's traumatizing for the very least. But it also can be a trigger of past trauma for many folks, especially when we're thinking about, as providers, how it may be triggering past trauma for a particular client that is seeking a service from us. Prior to the pandemic, it was already established that trauma-informed approaches are both appropriate and effective for engaging folks in optimal sexual and reproductive health care, excuse me. So active participation time again, and this is the third and final poll. How many of you are employing trauma-informed approaches in your work? And Jose, if you could launch poll number 3.
It is live, and so folks can see it on their screen.
Thank you so much. So for those of you that are calling in, the question is, how many of you are employing trauma-informed approaches in your work? And this is just choose one. And the responses are, we are actively utilizing trauma-informed approaches in our organization across all our services. 2, we are utilizing trauma-informed approaches in our organization in some of our services, one of which is the teleguided self-testing. The third option, we are utilizing trauma-informed approaches in our organization in some of our services, but not in the teleguided self-testing. 4, we are not using trauma-informed approaches in our organization at all. 5, I'm not sure if we're using trauma-informed approaches in our organization. And 6, I'm not sure what trauma-informed approaches actually are. So I'll give you a couple of seconds to respond. I'll do a time check.
Yeah, we're about 50% right now. And I put this in the chat, but we're having some good cross conversation. Gabriela, folks are offering some resources to each other. And if anybody on the call wants to share links to some of their intake forms, some of their marketing materials, please put it in the chat and we can include that in the follow-up materials following the series. We definitely like to highlight the work that people are already doing, right?
Yes. And I'm so glad you said that, Jose, because that's something that I should have made sure I clarified in the intro, is that because the purpose of this is really also for you all to learn from each other and share resources, everything that's kind of, like I said, I've been taking notes. I know Jose has been as well. This is being recorded. And anything that's in the chat, like, we will be part of the sort of package you're going to get along with the slides after this. Just please do fill out the evaluation. But yes, you'll be getting all this information. So why don't we close out the poll, and Jose, if you wouldn't mind sharing the results.
So folks can see the results on their screen right now, but the majority of our respondents said that they are not sure if they are using trauma-informed approaches in their organization, and that was about 46%. And then following that, we are utilizing trauma-informed approaches in some of our services, but teleguided self-testing is not one of those. And then our next highest responses were from we are actively using it across the entire organization to not using it at all. And those were tied at about 2 or 3 folks.
Okay. Excellent. Thanks, Jose. So again, like I can't see the results, but so I really appreciate, Jose, that you're sharing that with me. But from what I'm hearing, it sounds like, again, it's a range. And so I'm hoping that this next section is really informative and that it may be something that prompts some discussion for those of you in your respective organizations with, if you are a decision maker or with decision makers or program implementers, considering the use of trauma-informed approaches when it comes to telehealth services and the virtual teleguided self-testing. So, but again, to make sure that we're all on the same page, I want to make sure that we all have at least a fundamental definition for what trauma-informed approaches are. So, sorry, let me just move this from my screen. So these are the 6 guiding principles to a trauma-informed approach as developed by the CDC's Office of Public Health Preparedness and Response, or OPHPR, in collaboration with SAMHSA. SAMHSA is National Center for Trauma-Informed Care. And we can apply these 6 principles to increase awareness of the impact that trauma can have in the communities where we work. So SAMHSA's 6 principles that guide a trauma-informed approach include 1, safety, 2, trustworthiness and transparency, 3, peer support, 4, collaboration and mutuality, 5, empowerment and choice, 6, cultural, historical, and gender issues. And again, you'll be getting the references for all of this. But I want us to think about how being trauma-informed providers can help in those telehealth engagements when there are so many challenges to establishing rapport and conducting the risk screening. So as telehealth expansion has occurred nationally out of a necessity during the COVID-19 pandemic, trauma-informed virtual care has the potential to ensure and even expand continuity of healthcare services and engagement with our communities by fostering safe and collaborative interactions between clients and community members and healthcare providers, including those of us that are non-clinical providers offering HIV testing and other services. And so I'm going to share this with you all. So I grew up speaking Spanish. Spanish was actually the first language that I learned. And so the acronym of trauma-informed approach is TIA, which in Spanish is TIA, which TIA means aunt. And so I like to think of these 6 guiding principles and the trauma-informed approach as the tias, as the aunties, as those members in our families and in our communities that are so valued, trusted, and bring comfort and education. Like I can just share with you from my experience, like there were certain things that I would ask my tia that I definitely would not have asked my mom and dad. But just so that we're all on the same page, I want to make sure that we understood what is meant by trauma-informed approaches and their principles. So those are the principles, but what actually is the approach? And so according to a trauma-informed approach, a program, organization, or system that is trauma-informed realizes the widespread impact of trauma and understands potential paths for recovery. And so by recovery, I don't mean necessarily recovery from a particular illness or from a specific like substance use issue, for example. I just mean sort of recovering from the effects of and the impact of the trauma experienced. Recognizes the signs and symptoms of trauma in clients, in our community members, families, staff, and others involved within your system, your organization. Responds by fully integrating knowledge about trauma into policies, procedures, and practices at your organization. And ultimately, the trauma-informed approach seeks to actively resist re-traumatization. So an important note, a trauma-informed approach can be implemented in any type of service setting or organization, but is distinct from trauma-specific interventions or treatments that are designed specifically to address consequences of trauma and to facilitate healing. And so that's an important distinction. So I've said a lot, and I'd like to debrief and give pause. What questions do you all have? And I'll just wait a little bit to see if there are any questions.
And since we did get some folks saying that they were actively implementing some trauma-informed approaches, maybe they can also share about that experience as well for the rest of the group who might be interested in following in your footsteps or walking beside you.
Absolutely, yes. If you have any pearls, any nuggets, any words of wisdom, or if you feel comfortable sharing like some of the challenges you're experiencing in utilizing trauma-informed approaches along the way, we'd really appreciate your sharing. And we'll give a couple of moments to that.
And I like the association you did between the acronym and the word DIA. That's definitely, I'm gonna borrow that.
Yeah, and auntie, you know? So it's not necessarily that it's a separate sort of program component, but it's complementary, and it can really address some of the, again, I think just being realistic about the fact that we're all going through this global pandemic together. And so it can be very traumatizing at the individual level, at the community level, and obviously we're seeing at the larger structural level. But that's also not just for our clients or our community members, but for ourselves, our staff and colleagues, our organizations.
Yeah, we do got a hand raised. Crystal, if you want to go ahead and hop off mic or ask a question, feel free.
Yeah, so I currently work at a Department of Health for the city of St. Louis. And right now, I think on the poll, I put that I'm not sure if we're using trauma-informed approaches, but after your explanation of what that was, I do feel like we are. We can always, be better at it, but we too are not, we don't have a self-testing, don't have a self-testing mechanism like in place right now. And being a government organization, that that red tape is always going to be there. So what we're trying to do and what I've proposed is to collaborate with local organizations, specifically trans-led and centered organizations that have change and address the pandemic through like necessities and essential deliveries for folks who have transportation issues or just have needs and need basic you know toiletries and things like that. So we got the okay from them at least to start including requests for the self-tests. And hopefully we can, on our end, we can start promoting that as well and having that be the like bridge between a public health organization that, you know, already is sometimes seen as untrustworthy, and then a community-based organization that is deemed trustworthy, and having them be the ones to offer and to supply that test, as long as we're the ones following up with the counseling sessions and, you know, assisting them with the with administering the tests successfully, and then, you know, doing linkage to care and things like that.
Gotcha. Thank you so much for sharing that. I think that's such a wonderful approach, and from what we've seen in the literature and in reality, like that is so effective to have these sort of really mutually beneficial partnerships with health departments, community-based organizations, recognizing that they have the skills, the expertise, and the trust of community members. I think that, you know, it can never hurt, like what you said earlier about like, oh, I wasn't sure if we do trauma-informed approaches, but then when I saw, it can never hurt to actually have that somehow in documented in policies and procedures. Because considering that, you know, there may be turnover in an organization, especially when you start to do these partnerships where you're all on the same page. Like if CBOA is employing what they define as trauma-informed approaches, and Health Department B is implementing what they think is trauma-informed approaches, like, is it actually a trauma-informed approach that you're both implementing in the same way? Does that make sense? I hope so. But if not, you can always to me and ask. But so I do want to make sure that I'm respectful of everyone's time. And so we're about 15 minutes out. But I just wanted to share that adopting a trauma-informed approach is not accomplished through any single particular technique or checklist. So it's not like boom, boom, boom. It really requires constant attention, caring awareness, sensitivity, and possibly, and I will say in parentheses, usually a cultural shift at an organizational level, regardless of whether that organization is health department, clinic, CBO, grassroots org. And actually, I don't know why I did that hierarchy. I see that all actually this way. Excuse me, ongoing internal organizational assessment and quality improvement, as well as engagement with community stakeholders, will help to embed this approach, which can be augmented with organizational development and practice improvement. So when thinking about how trauma-informed providers can help in the telehealth engagement, when there's so many challenges to establishing rapport and conducting risk screening in the telehealth environment, it really shifts our point of reference from an inquiry from what is wrong with you to what happened to you, and shifting from there to a more resilience-informed paradigm shift from what happened to you to what's right, what's going well with you. It's an approach that many of us are already utilizing to a large extent when we utilize motivational interviewing, when we use our ORs, for example, and when we're being strength-based and client-centered. We just may need to be extra mindful of the possible trauma that is being experienced under COVID and that we can't interact the way that we're used to, which is face-to-face, in person, as part of the testing encounter. And that's where we'd like you to consider where trauma-informed approaches can really be useful and applicable. This is adapted from the Center of Innovative Practices, Trauma-Informed Care in a Telehealth Environment, which was put out in 2020. And again, this will be shared with you. Key considerations that we should think about when we move forward with our HIV testing efforts, particularly our self-testing efforts, and if it's teleguided. Realize that it's hard to focus on previous testing goals right now. Everyone's goals are safety and survival. Think about putting basic needs first. Understand basic crisis management skills, including safety planning. Utilize and encourage anxiety reduction strategies. Activate both provider and client or community member resilience. So I think this is important for us to consider ourselves as providers, for our organization, and also for the communities that we serve. We wanted to share some information though about what is and is not allowable to be HIPAA compliant with services you may be engaging in when it comes to teleguided self-testing or thinking about doing. So either for your own organization, you all in health departments, jurisdictional level and or grantees, public-facing options that are not allowed. Public-facing communication modalities are not allowed to be used in the provision of telehealth by covered healthcare providers include the following: Facebook Live, Twitch, TikTok, and similar video communication applications. Things that are allowable, non-public facing telehealth operations during the COVID crisis. HIPAA compliant options are Skype for Business, UpDocs, VC, Zoom for Healthcare, Doxy.me, Google G Suite Hangouts Meet. Non-HIPAA compliant options are Apple FaceTime, Facebook Messenger video chat, Google Hangouts video, and Skype. And I have heard from folks that are providing direct services, depending on whether it's the engagement recruitment side of things or follow-up or another aspect of the testing service, there may be a combination of what they're using. Again, this is referenced from the Center for Innovative Practices and will be shared in the references. Here's some pointers, because these are all crucial to establishing rapport and ultimately creating an environment where doing the risk screening and assessment can take place. So some pointers for teleguided HIV self-testing. Ensure privacy as much as possible to the extent possible. Eliminate or minimize background noises. And if you take notes during the session, let the client know so that they don't think that you're responding to an email and or not paying attention. So, you know, if I'm taking notes, which I was kind of doing earlier and I didn't prompt you all, it may look like I'm just kind of zoning out, or maybe that I'm playing like a game or something. So let your client know, like if you see me looking down, I'm taking notes, or depending on your screen, I may be thinking that I'm looking at the camera straight on, but it looks like I'm going to the side. So to be mindful of those things. Some more considerations. We may be changing the modality, but at its core, we're not changing the help. But we need to be mindful of adjusting our expectations for what can be achieved. And we really need to be employing resource and support building interventions. Finally, when it comes to engagement with our community members, it's important to name these, I think, because it's the reality. Initial engagement and maintaining engagement is more challenging with telehealth, and especially more so during COVID-19. Let's utilize the shared experience of COVID to join with community members. None of us have been in this situation before. It's all new ground for all of us. Help your community members to stay connected, to feel a sense of connection in the world, even though there's physical distancing. Help folks feel that they are not alone. And finally, at some point, and some of you may have already been doing this, I foresee that this is something that's always going to be an option moving forward, that we have to be offering tele services along with in-person services, and that we all have to be prepared to kind of very nimbly switch to all telehealth for a while. But when we think about transitioning back to in-person testing in non-clinical settings, we are going to have to implement new protocols if we haven't already. Honor preference about in-person response. We have to consider new physical health safety protocols needed for in-person response. We have to consider the need for an availability of personal and protective equipment, and then having our staff trained on how to utilize those appropriately and having proper spacing and ventilation. So we're 9 minutes out. What questions do you all have? And I see that we have sharing of resources, a Google request form. Thank you, Nkechi. Yes, Jose, thank you. Please make sure that you complete our evaluation. Nkechi shared their email. Thank you. Yes, for the person that for the participant that asked about sending the presentation, yes, we're going to be sharing the presentation, and we're going to be posting the recordings later on. Give us like about a week. Yep. I'm just looking through. So if you see me kind of squinting my eyes, that's because even though I just got new glasses, my eyes are getting old, y'all.
Yes, and I also want to encourage folks, like Gabriela said at the beginning, this is a learning community, right? So feel free to ask, if you want to hop on the mic and ask a question of a colleague you see on here, or anything, feel free to let us know, so that we can make sure to be that bridge, or you can ask them right now.
And I do want to recognize that this is obviously, like, we're all in this novel situation of COVID. This may be new content for you all. This may have prompted some thoughts that you might need to process. So it's absolutely okay if, like, you want to take some time, but then you want to reach out to any one of us, Jose or myself. That's absolutely fine too. And thank you to all of you that have been giving me like moral cheerleading and saying you're enjoying this. But so also to let you all know, while you're percolating questions, that there are other potential technical assistance topics that we can happily help you with. So pharmacy-based HIV testing and motivational interviewing, electronic health records and collaborative practice agreements. So someone was mentioning earlier about, partnership with the health department and CBOs, coupon incentives and pharmacy-based programming outreach and retention. That's actually something that could also be adapted as a strategy for follow-up. I think someone was mentioning earlier, our colleague that shared with us from Puerto Rico about follow-up and maybe strategies for increasing the follow-up rate. And then CLIA and non-traditional partners for testing, and more at your request.